Shall we start?
Yeah, you can go ahead.
Can start, ma'am.
Yes, please start.
Good evening, all. On behalf of Indian Society of Anesthesiology, I warmly welcome you all for today's ISA National Online PG class. I am Dr. Sirisha, attending as consultant anesthesiologist at Hyderabad. I'll be your screen coordinator for today's session. These classes are organized every Monday evening to strengthen the postgraduate teaching and provide a national academic program for all the students. Let us begin with uh, sorry. Let us begin with the session by evoking the blessings of Lord Saraswati to enlighten our minds. Sorry, sir, for the mild disturbance. Now, it's my proud privilege to introduce the Honorary Secretary, ISA National, Dr. Sukhmin Bajwa, sir, to please address us. Over to you, sir.
Thank you, Dr. Sirisha. Uh, I think from the last 2.5 years, more than that, we are touching the third component of our anesthesia, intensive care, and pain. So this is, I think, one of the first full-fledged class on pain management. And I'm really thankful to the team of Dr. Mithilesh, Dr. Shikha, Dr. Kriti, and Dr. Harsha. They have volunteered enough to be making them available to the national audience, facing such a large crowd as against a small crowd of a conference. So I think the any bombarding of all the questions will be dealt in a very nice manner. And more importantly, the topic is pediatric pain management. So you think of a pediatric anesthesia, your catecholamines levels become so high when you think of intubating a neonate or a infant. So similarly, the pain management in pediatric is so much challenging. You don't have any scales. You don't have a proper, analysis of the expressions. You don't have any validation of the pain scores, and you can't apply those pain scores on the pediatrics, relying solely on the clinical acumen, relying solely on the clinical parameters, and so many other things. But there is no definite way of, assessing, analyzing, and then deciding about the intervention. So it was always challenging for me because the pain is the most difficult topic for me also. At least today I will be enlightened to hear these stalwarts of pain. Actually, because the pain can be managed best by the young people now. Young people means just around between 35 to 50. These are the people who have learned pain because the pain medicine has evolved over the last 1.5 decades. And the modalities, the learning curves, and all the things which have emerged from the medical sciences, the pain is best understood by these people. There may be many people saying we are the pain specialist, but I think the team today we have got, you can easily gauge from the when the class will end that really pain management is, and that on to in the pediatric patient. So they have a volunteer to take up a very challenging topic today. And I think it is a boon for the PG students, and they will relish it, they will enjoy it, and it is also good for the theoretical and practical aspects. So without waiting much, Sirisha, I request you to introduce the faculty also.
Thank you so much. Today, it's my privilege to introduce today's faculty, and we have Dr. Mithilesh Kumar Mishra, sir, who is a senior consultant, anesthesiologist, pain and palliative, sorry, senior consultant, anesthesiology and pain and palliative care, and sir at Sir Gangaram Hospital, New Delhi. His special interest in pain and palliative care and the achievements are Fellowship of Indian Academy of Pain Medicine, Fellowship in Interventional Pain Management, National Fellowship of Pain and the Palliative Medicine, Fellowship in Onco Anesthesia and Perioperative Medicine, and he is a member of International Society of Study of Pain and a founder member Society of Onco Anesthesia and Perioperative Medicine, and he is an instructor in American Heart Association courses. He is a book editor of COVID-19 pandemic and the anesthesiologist and the pain management made easy and many national and international publications.
Thank you, Srisha.
Welcome, sir. And Dr. Shika Sharma, who is a co-chairperson, Institute of Anesthesiology, Pain and Perioperative Medicine, and she at Sir Gangaram Hospital, New Delhi. Her teaching experience is around 33 years of experience, and her special interest is anesthesia for thoracic surgery, transplanting surgery, and laparoscopic surgeries. The achievements of her fellowship coordinator in anesthesia of thoracic surgery. She was an invited guest faculty for various national and state conferences and an organizer for and updates and the CMS in Delhi. She is an executive member in ISA Delhi, and she edited a book of Clinical Thoracic Anesthesia 2020. Author of chapters in book Anesthesia for Transplant Surgery, Anesthesia and Laparoscopic Surgery, and she had many several national and international publications.
Thank you, Shrisha.
Thanks. Welcome, ma'am. Our third moderator is Dr. Kriti Puri, who is a consultant at Sir Gangaram Hospital, New Delhi. And she had a 15 plus publications in national and international field index journals and authored book chapters and narrative review of pediatric regional technique. She served as a guest lecturer for various national and international conferences and works, and she got a best podium presenter at AURA and ISA conferences. She had a ASPA certified PPLS provider and EDRA, and her core interest was pediatric anesthesia, regional anesthesia, and medical education. Welcome, ma'am.
Thank you.
Before we proceed, few rules to the audience. The audience should be kept mute throughout the class, and any queries and questions can be kept in the chat box. All the questions will be addressed at the end of the session, and all the audience, please keep the video off during the class. The MCQs asked in between the session by the faculty, and the participants are encouraged to type in the chat box, the answers in the chat box. With this, I hand over to the faculty and to please take handover. Thank you, ma'am.
Shikha ma'am can give an overview over this our part. Shikha ma'am, please.
Okay, so today we are starting with pediatric pain management. And as Dr. Sukhvinder has said very rightly, that it is a difficult course to embark on because we are mostly relying on the facial expressions of the child because the child cannot express. And starting from the time when we thought that because the nerves or the pathways are not well developed, the children or the infants do not feel pain, to our understanding that pain is an important part which has to be addressed. So, without taking much time, let's start today's session.
Shall I start, ma'am?
Thank you,
Yeah.
ma'am. Yeah.
Okay. Yeah. Kriti, so we start with you. Yeah.
Is my screen visible?
Yes, it is visible.
It's
Yeah.
visible, right? So, good evening, everyone. Distinguished chairpersons, moderators, and dear audience. And at the outset, I am very, very thankful and excited for this wonderful opportunity which is bestowed upon me by the ISA team. And I wish and I hope that whatever we discuss today is of use to everyone. So, the topic today that is given to me is acute perioperative pain management in children, a case based perspective. So, unlike the usual format of the class, what we'll try to do is make it really practical, really interactive for all the PGs so that you actually, after this whole session, you end up learning something which is very practical. So we all know that pain management is in children is complex and evolving, and integration is required, which has to be a multimodal strategy. So it has to consist of not just a pharmacological, that is a systemic analgesia, but also a form of regional anesthesia is encouraged in this sort of multimodal strategy. And how case based learning provides clinical relevance is what we'll discuss today. So let us take on the first case that we encountered. So this was a 4-year-old male for thoracotomy and decortication. He was weighing roughly around 14 kgs, and he came with us. He came to us with a diagnosis of large empyema, which was not responding to medical treatment, and even the ICD that was in situ showed thick pus and it was almost blocked. How about his vitals? So his vitals were fairly worsening. He had a room air saturation of around 93 to 94%, and he had worsening tachypnea and dyspnea as told to us by the PICU team. And the heart rate was around 110 to 115 beats per minute, and a BP of roughly 84 to 90 mmHg systolic. His his baseline investigations were the following. So he had a hemoglobin of 10 grams per deciliter, total count of around 14,000 per microliter, and platelets of 1.2 lakh per microliter. So what were we expecting? Yes, severe post-thoracotomy pain, right? So, what are the pain management challenges that we are going to face? We know thoracotomy is one of the most painful pediatric surgeries that we ever encounter, and that is what necessitates long-acting continuous modalities which are needed for analgesia. And the concerns here specifically for this case are that there's a high risk of post-operative pulmonary complications that we are expecting by virtue of the pulmonary mechanics, the respiratory drive, all of which is already compromised. And on top of this, because of the patient's pre-existing respiratory compromise, what we have to keep in mind is make our opioid use very judicious. I won't say opioid sparing or opioid free, which has become a new concept, but at a PG level, at a basic level, what we need to understand is that yes, we have to keep it judicious, if not minimal. Along with this, concomitantly, what was the TLC count was 14,000 and a borderline platelet count of 1.2 lakhs. So these are also very crucial in considerations for regional anesthesia. And our a multimodal triad principle has to come into play here, which is that it has to be a triad of regional anesthesia, some parenteral form of NSAIDs and opioids. So what was our plan in this case? I think we're all barely in sync with the fact that a thoracic epidural in such cases would be gold standard. So I have a video of this. What I want everyone is to look very carefully at as to how it is different from that of a adult patient. So please look carefully. As you can see, the first thing that you see here is that the needle. So this is a smaller needle. So as compared to the standard needle, here we are using a 4.5 centimeter needle, and here the markings that you get are at 0.5 centimeters instead of the adult one, which uses 1 centimeter. And as you can see here, I'm using LOR to saline instead of air. And that's a personal preference. You don't have to make any conclusions from that. But yes, as you can see, just see the length at which the LOR has been secured, and the length of the catheter which has to be inserted also. So everything is proportionately less. And very important thing, I hope that everyone notices that the aspiration which was done was with a 2 cc syringe. So the younger the child, the veins are more, they become more and more collapsing. And that is why if you use a 5 cc or a 10 cc, even though it is intravascular or something, it might not get aspirated. But when we give the drug, it will immediately go into the vascular space. So that is why the smaller syringe that you use, it's a better. So yes, we marked the, so that was our plan, to give a thoracic epidural, and we secured it very well. But oops, when this was only a plan, which was a mind map. But in the morning, when we saw the patient, the PG came running to us and said that we had sent the INR in the night during PHC, and morning when we are supposed to take up the case, the INR is 1.6. So I hope this cartoon says a lot. So you cannot just be fixated on one option which you are well versed with. So this is the importance of planning a strategy. So yes, the gold standard is a thoracic epidural, and it provides excellent dynamic analgesia. However, we need to have a plan A, B, C here as well, like we normally do in a difficult airway. So what is the next plan that was what we can have is probably a paravertebral. It gives unilateral analgesia. We'll be talking about this in a bit. And it has uh, a fewer side effects. The third option that we could have here is a erector spinae block, which is relatively easier, very much in vogue. It's probably the new kid on the block right now. The next one is, of course, a SAP block, which will not provide a superior analgesia as compared to thoracic or a paravertebral, but enough for the patient to at least be comfortable. Of course, the other options that we have are a retrolamellar block or a systemic analgesia, of course, in the form of IV opioids, NSAIDs, etc. Now, in any of the blocks, we'll be talking about the adjuncts when I'll be talking about each of them. Right. So what about the paravertebral block? So the paravertebral has a renewed interest. It was originally a very old block, then went out of practice, and now again it started. And we know it provides unilateral analgesia, and the quality of post-op analgesia is almost equivalent, if not as good as epidural. And it may be there's a lot of conflicting evidence on it in research, but sometimes when there's some kind of a borderline INR, it can be used if we take into consideration the risks and the benefits. So this is how we do a paravertebral. We saw the patient, we positioned him, and a bit about the sonography also let me discuss here itself. That sorry, the anatomy also let me discuss here itself. So we know that, one second, I'll just use my pointer. So at the PG level, I know all this sounds gibberish, but what you need to understand here is that this is the vertebral body, okay, and this is the spinous process. This is the transverse process. This is the back of the patient. This is the lungs. I'm trying to make it very simple for all of you so that you understand what I'm trying to say. And what this is our target area. This is the spread where the drug is going to spread. So as you can see, these are the muscles, the trapezius. I remember it by the mnemonic tree. So TRE. So this is how it goes: the trapezius, the rhomboid, and the erector spinae. And here is the costotransverse ligament, right? So this is the paravertebral space, this wedge-shaped space that you can see here, right? But oops, who said no? So it was the surgeon. So once we decided that, okay, paravertebral is our choice and we are going to do this with the help of an ultrasound, but the surgeon said no. The surgeon had a bad experience in a previous patient where while putting the paravertebral, the pleura space had got injured, and that is why he was totally not okay with this block. So just a word about this block. So as you can see, this is the paramedial sagittal plane. And here, what you can see is this is the transverse process, this one and this one. So the lung here, this hyperechoic white line that you see is the pleura. And this space is the superior costotransverse ligament. So our injection, our needle, as you can see in this picture also, comes in plane from here to here, and this is where the drug gets deposited. So if you are able to deposit the drug here, this is the paravertebral, ultrasound guided paravertebral. But like I told you, the surgeon was not very happy with it. So what is the third option that we got? So this was the third option, ESP. It's a relatively new thing, but very, very promising evidence that we have found with it. Relatively easy block, and a lot more benefits that I'm going to discuss later. So this is where I put my probe here, as you can see, and this is the sonoanatomy, what I can see here. So as you can see, this is again the same thing, the trapezius, the rhomboid, and the erector spinae. One second. Right. Yeah. So this is how it is. And again, my needle comes here till here, almost touches the transverse process and lifts this space. As you can see, this is the one. This is the ESP block. So this is a video, real-time video. So again, as you can see, these three muscles, the trapezius, the rhomboid, and the erector spinae, these are the transverse processes. The sliding thing that you can see, I hope you understand, this is the pleura. So that's what we are discussing. If you can hear the video, that can we do this block out of plane? And the answer is that in plane is obviously more safer. Okay, so what I do here is my needle comes like this and hits here. And once I hit this transverse process, I give my drug here after aspirating. So what is the dosage? So in general, the dosages of the ESP and the paravertebral, for that matter, even the epidural as a bolus are almost the same. So it is somewhere from 0.3 to 0.5 ml per kg, and the drug that I'll be giving for this kind of a child would probably be 0.25% levobupivacaine or bupivacaine or 0.2% ropivacaine. A higher concentration can also be given, but you have to keep in consideration the hemodynamics of the patient. And this kind of patient who's already uh, deteriorating, worsening, I don't want the patient to further probably get deteriorated from this. So this is the concentration that I would be preferable, and in this volume. The continuous infusions I'll be talking about later. So, what I need you to understand from these three scenarios that we created is that each block has its own advantage and disadvantage. And if you understand that, you can put into account according to the case that you have encountered on that particular day. So we know that the gold standard, like I told you, is a thoracic epidural, which provides excellent analgesia, and it is very dynamic, provides bilateral uh, superior analgesia. Compared to a paravertebral, which is almost equal but provides unilateral analgesia. Now, in this case, had we even gone ahead with a paravertebral, the thing which has to be borne in mind is that you have to give it at two places, and when that happens, the drug has to be adequately adjusted. Compared with the ESP, which is also good, a lot of promising evidence has come up in the present in the research papers about the quality of the ESP block also. Technical difficulty, of course, the thoracic epidural and the paravertebral are almost the same. They are technically difficult, especially in a pediatric case, like I was showing you in the form of that video, that there are a lot of considerations that are specifically there for pediatrics, that even the precision is much more than that of an adult. Just a 0.5 centimeter here and there is going to make or break the picture, compared to a ESP block, which is relatively very easy to master. The side effects, of course, we all know, but what I mainly need you to understand in this scenario was that safety in deranged coagulation. So, yes, epidural is a big no-no. When there is a lot of sepsis, when there's the coagulation is deranged, is a big no-no. Paravertebral, although it was always believed that it was a big no-no, and since it's a deep block, what I would like all of you to understand is that if the INR is severely deranged, please don't go ahead with this block. However, there's a lot of evidence which suggests that if the INR is slightly deranged or the patient is just borderline, you could probably risk the other, you could weigh the other risks and benefits. And if you feel that this is going to be a good option, you can go ahead with this. Whereas the ESP block has no such issues. So it's a completely safe even when the coagulation is deranged. And that is the major plus point of this block. So the same thing that right now we spoke about is what I have written here. There's nothing that I think ESP and even the SAP block for that matter is a very new block, and it is showing very promising evidence. The only con of a serratus anterior plane block is that it may not cover the visceral component, and that is why it is considered to have inferior analgesia, probably when compared to even a ESP block. And that kind of a situation does not exist for, of course, the thoracic and the paravertebral blocks. So this is what I already told you about. The most important thing is that we do not leave the patient here uh, just immediately post-op. We feel that, okay, the surgery is done now, the pain is not our headache, the surgeon and the PICU people will take care. Please don't do that. So the post-operative plan of analgesia is equally important, and that is why it is a perioperative strategy that we have to make. So we have to maintain the regional anesthesia, and this is through, in the case that we have just now discussed, with a continuous infusion, preferably, whether it is of epidural, a paravertebral infusion, or even for that matter, an ESP catheter that we can put. And along with that, of course, we need to give IV paracetamol in the dose of 15 mg per kg. And of course, if there is a breakthrough pain, we have to treat it with judicious use of IV opioids. What is very important in such things is monitoring these patients, and especially for the pain as well as for respiratory monitoring, given the preoperative status of this patient. So let's go on to the second patient. So the second case that we had was a 8-month old female, and she was weighing around 7 kgs, and the diagnosis for her was intussusception. Her pre-op status was that she was mildly fluid depleted. Her heart rate was around 124 beats per minute. Her BP was hovering around 80 to 40 millimeter mercury, and her saturation was 96%. Her investigations, her HP was 9 grams per deciliter, TLC of 16,000, and platelet of 2.2 lakhs per microliter. And here, yes, we did have a PT-INR pre-op itself. So what are the challenges that we have to face in this case? Yes, the patient is already an infant, so very highly sensitive to opioids and very prone to respiratory depression. The pain here that is going to arise again is a visceral pain, deep pain. And there's a high risk of aspiration, fluid deficit, shifts, etc., probably even sepsis. And since this is a smaller child we are talking about, there's a lot of altered pharmacokinetics and immature pain pathways are present. All this makes the respiratory reserve limited and gives us a narrow opioid safety margin. And the technical considerations for regional blocks in such small infants is even more important. So this time we came up with the strategy before itself. So what did we see? So there was a caudal epidural, which was our first option, whether single shot or even a catheter. So that depends on the incision and on after talking with the surgeon. The second option is a tap block or tap plus minus a rectus sheath, depending on where the incision has to be made. The third, of course, is a systemic opioids, which have to be, again, very, very carefully titrated. And along with that, IV, PCM, etc. can be given. Now, here, a very important thing is that the pain management strategy is based on the delicate balance principle. So, yes, we have to provide a very adequate analgesia, but at the same time, we have to avoid the profound side effects of the systemic drugs that we are giving. So here it's less about the pain control, but more about maintaining homeostasis in general. So our first plan A, was caudal. So I'm sure everybody thinks nothing could go wrong. The INR is there, everything is okay, correct? And we are good to go. We know what we can see. So we'll just briefly discuss. So as you know, once we make the patient lateral, these are the two the landmarks that we can see. This is the PSIS, that is the posterior superior iliac spines, and this is the sacral hiatus. And right here, between the sacral cornua, is where our needle has to be positioned. So the caudal dose, this is something very, very practical, but most of the times I think we tend to forget this as PGs. So just to reiterate, I have put this slide. Please do remember this. So this is this is as per the modified Armitage formula. So the maximum volume that can be given is 20 ml. Please remember this. And in case of only sacral coverage that is required, 0.5 ml per kg is more than enough. For thoracolumbar, it is 1 ml per kg. And for mid-thoracic spread, 1.25 ml per kg is the recommended dose. However, if the dose in mg per kg is getting exceeded if we are using this dose, then it is advised that we lower the concentration. And the additives here that we can use are fentanyl, morphine, clonidine, etc. So we positioned our patient and what did we see? So again, boom, there was a problem. So we saw that there was some bluish discoloration here. So a bluish discoloration, a sacral cleft or a tuft of hair in this space is a relative contraindication. We have to, everything has to be done with a lot of carefulness after this. So what was the next option that we had now? We can get the same block, but with ultrasound. So if with ultrasound, everything is visible, it's seen well, then we are good to go. So this is a actual case where this was done. So as you can see, that was in the long axis, this is in the short axis. I prefer to do it in the long axis because in plain needling is possible. So as you can see from here, I hope you could all see the drug spread. So this was the sacral conva. This is the drug spread into the caudal epidural space. Right? So this is a very, very viable option which can be done. But of course, this can be done only after a careful discussion with the parents and the surgeon. Oops, but the parents didn't give consent. So this is a very practical problem that when you discuss such things with the parents who are already very anxious, and on top of that, if there's some kind of an unanticipated problem, they are bound to break down immediately and might not be able to take the best or the correct decisions. But we have other options, so nothing to worry. So what was our next option? So the next option that we have is a tap block, a plus or minus a rectus sheath block. So let's go on to the rectus sheath block, the first. So as you can see, this is the midline. This is a very simplified form of where the sensory coverage of a bilateral rectus sheath block is. So it's mainly here. So when you scan this area, this is the rectus abdominis muscle, this is the linea alba, and this is on the laterally, much laterally, what we see is the external oblique, the internal oblique, and the transversus abdominis. And this is where is our target area, that is the anterior cutaneous branch of the intercostal nerve. So once our needle has to come here and it has to sit here, the local anesthetic has to be deposited here, that is in between the posterior and the posterior part of the rectus abdominis and the posterior rectus sheath. So this is where a block has to sit in, and this is a very, very practical thing of where our blocks act. So as you can see that this large black circle is where the rectus sheath, like I was telling you in the earlier slide, provides coverage. Then this one, the area shaded, this one is which is covered by the subcostal tap. But most of the times, this area is covered by the bilateral, the standard, the conventional tap block. So once we, if a bilateral tap is combined with a rectus sheath, most of the, or at least a lot of surgeries that we routinely do in pediatrics might be covered. But if we have to go into further depth, then this is how it is. So in case of flap hernia incisions, for example, so here what do we do? So here what do we do is that we give a bilateral tap again, which is most of the time sufficient, and maybe a paraumbilical rectus sheath block. Correct? And 1 second. Yeah. So in case we have some intestinal obstructions or some laparotomies where there is a rooftop, Mercedes-Benz, such kind of incisions, then a bilateral rectus sheath block along with a tap block, which is the subcostal approach, might be beneficial. Uh, yeah. Then again, if there is a coccus incision, then what would be ideal? Again, is the same thing, the tap, subcostal tap with the rectus sheath. And in a midline laparotomy, what we can see is the what will be useful is the bilateral rectus sheath along with the classical tap block. So here's a video. This one was taken really long back, actually, to be honest, when I was doing my fellowship. But I hope you can see that this one was the linea alba, this is the rectus abdominis, and this is the drug spread. So as I hope you can see that this was the rectus abdominis, this was the posterior rectus sheath, and we have deposited all this drug here. So now coming to this, so again, what are the advantages, disadvantages, and what are the salient features of all these three options is that the caudal block, the tap, and the rectus sheath. So the analgesia coverage definitely is superior with a caudal epidural as compared to a tap block or a rectus sheath block. And similarly, the duration can still be adjusted. In case we're giving a single shot, we can add an adjuvant with it in the form of maybe morphine 30 mics per kg. 10 to 30 mics per kg is the recommended dose for as an adjuvant. Or even fentanyl 0.5 to 1 microgram per kg, clonidine 1 to 2 microgram per kg. All of this can be given as in a single shot. Whereas in the catheter, we can prolong the action for as much as we want. Usually the catheter stays for around 2 to 3 days. We should try to remove it by the third day so as to not cause more infection. Technical difficulty, yes, it's a fairly easy block, but putting the epidural might require some finesse. Of course, motor blockade is possible only with caudal as compared to tap and rectus sheath. And there is a caudal failure rate. Yes, there is always a chance of an infection there. Even interosseous, intravascular, any of these injections can happen with a caudal. Whereas in case of tap block and rectus sheath block, usually this kind of complications are not there. However, in rectus sheath, what we have to remember is that the inferior epigastric artery is very in close proximity with our needle insertion point, and that is why we have to be extra careful when we're doing it. The duration of action of these is moderate. We can add some adjuvants and can prolong it, but there is no scope of catheter here. The technical difficulty, they are relatively easier blocks, especially when we're giving it with ultrasound, and of course there is no motor blockade which can be seen here. So this is the dosing consideration, and this is the crux of everything that we are going to discuss here. I think if we are good with the doses, if we are very fairly thorough with the doses, half the job is already done. So what I would like to stress here is that bupivacaine, levobupivacaine, ropivacaine, these are usually the most common ones that we are actually using. Yes, of course, the books mention lignocaine, prilocaine, chlorprocaine, and all of that, but usually these are the ones that we are using. Now, when the baby is around 10 kgs or less than 10 kgs or less than 1 year, a 2 mg per kg dose is sufficient, more than sufficient as a single bolus dose. That is, I'm talking about if we are giving. However, when we are talking about an infant who is more than 10 kgs, then for bupivacaine it remains the same, as well as for ropivacaine it remains the same. Levobupivacaine has a slightly increased safety profile, so 2 to 2.5 mg per kg. What is more useful is that the continuous infusions, which are something very, very important. So bupivacaine and levobupivacaine both have a concentration of 0.0625%, and when the child is less than 10 kgs. But when the child is more than 10 kgs, we can use an infusion of say 0.125% bupivacaine as well. This is something which is very important. So if the child is less than 10 kgs, the dose that we are using for infusion of a caudal, epidural, so on and so forth is 0.1 to 0.2 mg per kg. So please remember that this is more important than the one which we usually talk about, which is 0.1 ml per kg per hour. So it has to be, this dose has to be calculated first, and then you can run it at a 0.1 ml or 0.2 ml per kg per hour. But similarly, for kids who are more than 10 kgs, 0.2 to 0.4 mg per kg per hour is the recommended dose. Please do not go above this dose, and also this dose also is the upper limit. So once you feel that the analgesia is sufficient with a 0.2 mg per kg per hour, please don't run it at 0.4, because there's always a risk of accumulation in kids especially. Bupivacaine and levobupivacaine have the same doses, exactly the same concentrations also. For ropivacaine, we can use 0.1% ropivacaine at the same rate, and 0.2% in case of if the child is more than 10 kgs at the same rate. There was some technical issue with the slide, and that is why it's come all like some of it is blank. That's why I've been explaining it like this. So, what are the pros and cons here? We know that caudal is most commonly performed block, very good analgesia here, easily it can be performed, good safety profile, all of that. Tap and rectus sheath, safe, it's safe, may not give as good as analgesia as caudal, but is relatively um, uh, the the alternative is relatively okay. The cons, again, like I told you, visceral pain is not taken care of. So here also we need a post-op plan. So what is the plan? We have to continue the multimodal approach. We have to give the IV paracetamol. Opioids in the form of IV fentanyl may be used to as a rescue technique only for moderate to severe pain, with extreme caution and in a monitored setting. And very small children, even the non-pharmacological measures are very important, like swaddling, non-nutritive sucking, keeping them in a calm, quiet environment. All of that is there. So comparing the two cases, thoracotomy, yes, very severe pain. Laparotomy, moderate to severe pain. Gold standard for the thoracotomy is, of course, the thoracic epidural. Gold standard for this, for the laparotomy, is the caudal epidural. Alternatives in the first case were paravertebral and ESP. Good alternatives for the second case that we were discussing is TAP and a rectus sheath. Both require multimodal opioid minimizing strategies. So, this is the essence of the whole class, that if we understand balanced analgesia and how to tailor it as per our patient requirements, our job is done. So, the core principles here: individualized planning is very important. Having a strategy is very important. Strategy means plan A, plan B, plan C, and has to be modified dynamically every single time with every single patient. Multimodal should be our defaults. Regional anesthesia techniques are increasingly favored with ultrasound guidance, and should be encouraged, but only when we have the necessary expertise for it, because children, of course, are more delicate. And opioid has to have a judicious use, it enhances the safety, and we have to integrate all of this with our ERAS protocols. So I'll be starting with the questions. Do we have the screen coordinator with us?
Ma'am, Dr. Deepa,
Shirisha. Yeah.
Dr. Dr. Deepa Pant has a message just now. How will pain management vary depending upon open decortication or thoracoscopic decortication?
Sorry.
How the pain management varied depending
That
upon whether it is the open thoracotomy, open decortication, or thoracoscopic decortication.
So obviously, a open decortication, the pain will be much more, and that is because the thoracoscopy we are just using the ports, so uh, that pain will be relatively less. But that being said, even in the centers that I was previously working, they had a very strict protocol, the NICU and the PICU team, that they wanted epidurals, thoracic epidurals, even for their thoracoscopic cases. Even the thoracoscopic decortications that were there, they said that uh, their recovery was very good because that pain which was there was taken care of by our thoracic epidurals most of the time. So they highly encouraged it. But yes, the pain component will be slightly less in a thoracoscopic procedure.
True. One more thing is, even though it is thoracoscopic, but still they will put some drain, they will put some ICD.
Yeah,
That pain
definitely
itself in a kiddo,
is,
children,
is a
if we
lot.
plan a alternative that going for intercostal nerve block and all, that is very difficult in kids and require too much of expertise. So putting even a thoracic epidural for thoracoscopic procedure also is preferable. There we may require a bit lesser amount of analgesia,
Yes,
but for 2 or 3 days, it will be comfortable.
very true, sir. Very true.
Anything else, Shisha?
I was.
one more one more question
Can we
from
take the
So,
questions that
Dr.
I
Sirisha,
have
yes,
first?
yes, 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 yes. So, what we'll do, Dr. Sirisha, is we'll take up the questions in the chat box a little later.
Okay.
Now, Dr. Kriti will be dealing with the MCQs here, okay?
Yeah.
Okay.
So, let us just discuss the MCQs to begin with. And the first MCQ is, what is the most feared complication of paravertebral block in children? Is it local anesthetic, systemic toxicity, pleural puncture leading to pneumothorax, catheter migration into epidural space, or D, hematoma formation in paraspinal muscles? We will take up the other questions in the chat box slightly later, right, Dr. Kriti?
Yes,
Yes.
yes, sir.
Yes.
Absolutely, sir.
Great. So we'll just see what the answers are. And Dr. Sirisha, can you just coordinate the answers?
is
B.
most
Yes,
of the answers are B, sir. Two.
yes, yes. Can we
Gaurav,
have some more? Very good. Plural puncture. Can we have some more answers?
Yeah,
Yeah,
mostly it's
so I
B
think,
only. Yeah.
yes. So I had purposely used the excuses that I gave in each scenario as a answer to some of the questions. So since I mentioned specifically that the surgeon did not want paravertebral in that case because his previous case there was a pleural puncture. So I thought that these anecdotes somehow play a role, and they'll help us in remembering such things. So that is why the most feared complication of paravertebral, at least in children, is pleural puncture, which might lead to pneumothorax. So I think most of them got it correct. So I'm
So
happy.
they were attentive in class. So
yes,
it is otherwise okay. Yeah. Okay. Next question, please.
During placement of a thoracic epidural in a 5-year-old, the catheter is advanced 6 centimeter beyond the needle tip. The child later develops unilateral patchy block. What is the most likely explanation? Is it catheter migration into the paravertebral space? Is it inadequate test dose volume? Is it the failure to identify the epidural space, or is it the catheter tip that has reached the lumbar level? So what do you think is the answer?
Dr. Kiranjit, Prem Kumar, Pakshi Sharma, everyone had answered as A, madam.
Yes. So
The
catheter
audience are actually
migration.
encouraged to answer right or wrong. Even if you answer wrong,
Yes,
you'll
please
remember
do
it throughout
that at
the
least.
Yeah,
you'll
it
remember it
doesn't
throughout the
matter at
live.
all. Yeah, you should attend. You should attempt
Yes,
to
attempt
answer.
is important.
Yeah, don't worry about whether it is correct or not. That we will
Yes, yes.
discuss.
Agreed, agreed. I think my screen sharing was paused. Is it paused?
No, we can see your screen.
You can see my screen. Okay, okay, fine. Okay, so the hint here was that the 5-year-old child already 6 centimeter catheter has been inserted inside. So it means that it was a bit beyond what was normally required. So the most common catheter migration site in children is the paravertebral space from the epidural space. So during an ultrasound guided ESP block at T6 in a 6-year-old, which structure should the needle tip be placed beneath for correct local anesthetic deposition? Somehow I am not able to see either I see my screen or I'm seeing the audience only. I can't see both.
Yeah,
Okay,
it'll be
but the
difficult
screen
for
is
you to see.
visible.
Yeah,
Yeah,
I am
yeah,
not able to
yes.
see that.
yeah.
Okay. So if someone can
Answer
help
is
me with
C.
the answers, what are majority
C.
people answering?
Mostly they are answering C.
C
Yes.
is being answered.
Yeah.
Yes, yes. So what I've written here is it is placed beneath. So it is placed beneath the transverse process. As I explained in the video also. So just under the transverse process, if you put the deposit the drug, it's more than good. So the next one is a little tricky one, but I hope that in this one I hope that someone makes mistakes so that we can reiterate this point. So dose for circumcision in caudal for a 10 kg baby. So please listen to the options carefully. 0.5% bupivacaine 10 ml with IV morphine 300 micrograms. 0.125% levobupivacaine 3 ml with IV fentanyl 10 micrograms. 0.1% ropivacaine 15 ml. 0.25% bupivacaine 10 ml. So what do you think is the most appropriate one?
Mostly people are answering D.
Yes, yes, exactly.
There are
Some
two
had
ways.
made, as you said, some has answered B.
B for
B,
Bombay.
B
Q
for
as
Bombay.
Yeah, B
yes.
for
Okay,
Q,
so I have deliberately kept these options very close and very confusing so that we can have a 2-minute discussion on this. What I would like to reiterate here again is like I mentioned that so in case of a 10 kg baby, the maximum dose of bupivacaine that we can give is 20 mg. Is everybody in sync with this part at least? 20 mg bupivacaine is something that we can give, correct?
Yeah.
Now, when we are using 20 milligrams, that means the maximum 0.5% concentration that we can use in such a baby would be almost 4 to 5 ml, correct? So, we are exceeding from that dose in the first option. Is it understood? Am I clear with this?
Yeah.
Whereas once, if we are taking 0.25% bupivacaine, we can easily use 10 ml. So if this option would have said 0.25% bupivacaine 10 ml, then probably could have been a better option. Of course, morphine for a circumcision is a bit too over the top, but at least this dose is what I'm talking about. The second one, 0.125% levobupivacaine 3 ml might not give us that great an analgesia. Number one, we need at least zero point 0.5 ml per kg as per the Armitage scale. Okay, now as per that formula, at least 5 ml of drug should have been there. Also, 1 to 5 will be a bit too low concentration in the presence of this. So this is also lower than what is recommended, and this too. So that is why it might give us some suboptimal analgesia. Of course, the second best option in all of them will be this. If this option would, the D option wouldn't have been there, then this option might have been okay, but we are talking about the most appropriate one. What about the third option? Again, very dilute. 0.1% ropivacaine is something which is very dilute, and again we are giving 15 ml of that. So that much is not required for a circumcision. This much volume is not required. And the last option, which is our option, is 0.25% bupivacaine. Is it okay?
Yeah.
Okay. The next one then, during an ultrasound guided tap lock in a 5-year-old, which is the correct target plane for local anesthetic injection? Is it between the external oblique and internal oblique? Is it between the internal oblique and the transversus abdominis, deep to the transversus abdominis, or within the rectus abdominis? So this is a fairly
Yeah,
easy question. I'm not
100% marks.
expecting. I'm not expecting.
Scoring question. Yeah.
Okay, the next one is in a rectus sheath block for a 6-year-old undergoing umbilical hernia, where should be the local anesthetic deposited? Between the rectus abdominis and the posterior rectus sheath, between the skin and the rectus abdominis, between the external and the internal oblique, or between the peritoneum and the posterior rectus sheath.
I must thank Dr. Prem, Dr. Gaurav. They are always first to answer. Very good.
So what have they answered? Let's see.
A. Answer is
Yes.
A for everyone. Yeah, everybody is answering A.
Yes, so we saw in that video also of how the drug was being deposited between the rectus abdominis and the posterior rectus sheath. So that is the option, that is the answer. What is the most important safety concern during an ultrasound guided rectus sheath block? There's a risk of vascular puncture of the inferior epigastric artery. Is it the pleural puncture and pneumothorax? High incidence of local anesthetic systemic toxicity, or an unpredictable cephalocaudal spread?
Answer is A. Most.
A. Yes, we spoke about this also. So the inferior epigastric artery is very close proximity with this block.
That's why you put Doppler before
Yes.
putting. First thing is when you are putting a needle under ultrasound, all the time needle tip should be visible. And
Yes.
mostly these small arteries, we don't differentiate the pulsation. So the Doppler will ease you. The trajectory will be seen. Okay, next
Yes.
question, please.
A 7-year-old 25 kg with epidural catheter after laparotomy is running an infusion of 0.1 to 5% bupivacaine at 0.5 ml per kg per hour. The child develops drowsiness and circumoral tingling. What is the most appropriate first step? Stop the infusion immediately and give IV intralipid. Reduce the infusion to 0.2 ml per kg per hour and observe. Switch infusion to 0.0625% bupivacaine at the same rate, or give IV calcium gluconate.
Yeah, mostly the answer is A, and this is a very, very important. This is now IAPA recommendation that wherever you are practicing pediatric regional anesthesia, intralipid should be available inside the OT all the time, and we should know the management. Maybe if I get time, I will show you that slide. That this is the last management in pediatric is very, very important. We'll see it later. Next question. This is answer is correct for. But I wonder because 102
One.
people are attending and mostly the answer is coming for 3 or 4 persons only. They are repeatedly answering correct and they are only answering. I request others also to please pitch in. Yeah.
Also, in this, I would like to point out what is the, so for the sake of completion, what is the dose for the intralipid in ml per kg that we have to use? If somebody can put it in the chat box, yes, very good. So it is 1.5 ml per kg. And what is the rate of the infusion that we give? If someone can write that. So Kunal has written it correctly. If anyone else could tell about the infusion also. Nobody's answering.
Uh,
0.5.
0.5.
0.5 to 1, almost sometimes even 1.5 ml per kg per hour we have to go up to. Okay. The next question is hemodynamic stability compared with paravertebral SAP block is associated with higher incidence of hypotension due to the sympathetic blockade, greater risk of epidural spread, better hemodynamic stability because it is a facial plane block, or more frequent requirement of vasopressors intraoperatively.
Mostly they are answering C. Okay.
So I have seen that even though erroneously I have myself mentioned the answer, I'm just trying to see that how many extra people except for the regularly answering ones are answering.
Yeah, we had some new names. Thanks for the trick. Okay.
That was just for encouragement.
Okay.
Yes. So
Good.
we're done with the questions. And the answer, of course, is better hemodynamic stability. Okay. This is it. I think I'll stop sharing my screen.
Yeah. Thank you, Kirti. It was a wonderful lecture. We'll take, if any more questions, we will take after the second lecture also. We all are here. We'll finish all the answers. I think Harsha can start sharing the screen. By the time Harsha is sharing, okay, it's there. Okay. So Dr. Harsha Binu is our FNB in pain medicine at Sir Gangaram Hospital. And we are doing a lot in this pediatric pain
Is my
management.
screen visible, sir?
Yeah, Harsha, it is visible. Please start.
It is visible. Can you make it full screen, please, Dr.
Full.
Harsha?
Shall I start?
Yeah.
Yeah, please.
Perfect.
Good evening, distinguished chairpersons, moderators, and audience. I'm Dr. Harsha Binu, current FLB trainee in pain medicine at Sir Gangaram Hospital, New Delhi. So now that a major chunk of blocks has been covered by ma'am, I will be focusing on how do we recognize this acute pain and why do we need to recognize acute pain in pediatric population. So pain is a very distressing symptom, especially in kids. So when we think of a child who has to come to the hospital, he will be very apprehensive about the pain that he's going to get. It could be in the form of a vaccination, injection, IV cannula. So we as anesthetists, we should try to make this journey as comfortable as possible for the child. Now, if we see the global prevalence of postoperative pain in pediatric population, there are multiple articles which show that postoperative pain is undertreated. The prevalence is anywhere between 25 to 40% in the pediatric population. Now, why do children experience such a lot of pain? That we need to go back to the neurophysiology of pain in children. So all of us know about the pain pathway in adults. It's the same in children, like the nociceptors going to the spinal cord and then traveling up through the spinal column track through the brain.
I have sent you material for delegate faculty certificate and
So at this simultaneously, when the nociceptor is sending signals to the brain is also sending some inhibitory signals to reduce the pain. So these signals are called inhibitory signals. These signals are poorly developed at birth. And the second reason why children experience higher level of pain is because their nociceptive receptor fields are larger. And as you can see in the picture, the green one is the tactile fibers and the orange ones are the nociceptive fibers. There is a huge amount of overlapping at birth. And the third reason is that the fibers, the nociceptive fibers, they are composed of low threshold A fibers, which are later replaced by high threshold C fibers. So these are the reasons why children experience or perceive a higher degree of pain than adults. So that also makes it very important to treat pediatric pain. Now, there are a lot of challenges that we face while treating pediatric pain. One is that they will not be able to communicate effectively their degree of pain. And like I said, there's a lower pain threshold, and there's not enough studies or drugs that are approved for children. And again, not all children would cooperate with the assessment of pain. Now, talking about the assessment of pain, how do we assess it? There are three main strategies for assessing the pain. First is obviously self-reporting. The child will himself tell what kind of pain and the severity of pain is experiencing. And this is the gold standard. And two other modalities are by seeing the behavioral effect of pain on the child and also the physiological changes that pain can cause to the child's body. So the best would be to combine all three modalities to get a wholesome review about the kind and intensity of pain the child is experiencing. So coming to the first type, self-reporting. This is usually, we use this type of scale in children who are old enough to understand how it is being used. So it's for more than 3 years of age. And examples of these are visual analog score, numerical rating score, Wong and Baker Faces Pain Scale. So I will be going into the details of these. Numerical rating scale is a 11-point scale, as you can see on the screen, starting from 0 to 10, where 0 is no pain at all and 10 would be the worst possible pain. So this is approved for children between 8 to 18 years of age, and it is easy and quick to use. So even if we don't have a scale at hand, we can verbally also ask the child as to how much pain he's experiencing. Second similar scale is visual analog scale, which is just a single line with one end showing no pain and the other end showing pain as bad, like severe pain. So this is a 10 centimeter line, and we show it to the child and ask him to mark on this intensity of pain. So this is again easy, but you require a pen and paper, and we need to measure how much pain the child has marked on this. The third self-reporting tool is the Wong and Baker Faces Pain Rating Scale. Here we show this picture to the child with 6 faces, with again 0 to 10, with no pain and pain that hurts the most. This is for use for children between 3 to 18 years of age, and the child will choose how severe his pain is. Now this has a few disadvantages because the first smiley that is there is a very happy child. So no child who is in pain would be this happy. So this led to many children reporting a higher scale of pain. And again, at the other end, not all children who are experiencing worse pain would cry. So this was revised a little bit, where 6 mature faces were shown, again 0 to 10. And here we can see how we're showing the child on a paper, the faces, and how the child is marking it. Another self-reporting tool is called as Pieces of Hurt tool, which involves 4 red poker chips, as you can see on the screen. And you have to ask the child to pick like 1 poker chip if he has mild pain, 1 more if the pain intensity is higher than that, and so on. So this is a little time consuming. The chips may get lost and they might carry infection as you are moving from child to child. Now, for children who are unable to self-report, the children who are less than 4 years, who are too young, who don't have proper, who have impaired communicative skills, or who are restricted by sedation or mechanical ventilation, we have to combine the behavior and physiological impact of pain. Plus, there are a few observational pain tools which can be used in such cases. So in behavior of the child due to pain, there will be a change in the facial expression. The child will be crying, inconsolable. The pain would affect the child's appetite, sleep, and sometimes the child might be unusually quiet or lethargic, irritable. So we need to look at all these aspects. And the physiological aspect would be an increase in heart rate, blood pressure, decrease in oxygen saturation because of the increase in metabolic demand, and the respiratory rate might increase or decrease. And the observational pain scale that we most commonly use in such children is called the flat pain scale, which has 5 categories: face, legs, activity, cry, and consolability. And each aspect is divided into score of 0, 1, and 2. So the total score is calculated, and any score of more than 7 would be severe pain or discomfort in the child. And for children who are mechanically ventilated or in an ICU setup, there's something called as comfort scale, which again incorporates both behavioral and physiological aspect of pain. And you can see the components on the screen. So the score ranges from 8 to 40. And can anybody tell me what is the problem with these tools that I've mentioned? So all of these tools just tell us about the severity of pain. It does not tell us about the site of pain. So the Wong and Baker cases pain scale, Connie Baker from that, she fine-tuned her scale later on, wherein she showed children this diagram and asked them to mark on the diagram where exactly it hurts. And each point where it hurt was graded from 0 to 5 on the FACES scale. So this would give a more comprehensive approach to understanding the child's pain. So now that we know how to assess pain, there are different strategies to manage this pain. First, there is the pharmacological aspect, non-pharmacological aspect, physical management of pain like applying ice packs or hot fomentation or massaging, psychological aspect like relaxation techniques, reassuring the patient, and of course, there's regional anesthesia techniques. So the non-pharmacological techniques, they could be distraction, wherein you show the child there are options of swaddling, breastfeeding, kangaroo care, non-nutritive suckling. Now, when we are treating pain, we should have a multimodal approach. We should select drugs that act on different parts of the pain pathway. So we should combine drugs from this list. There is a WHO pain ladder, which was initially for cancer pain, and later it was extended to use in postoperative and acute pain. So for mild pain, we start off with NSAIDs and acetaminophen and add opioids if the pain severity is more. So for postoperative pain, we can de-escalate the pain. We can start with opioids and de-escalate from there, because postoperative pain is most severe immediately post-surgery. And as the days pass by, the severity of pain keeps decreasing. Now, why is it so important to treat acute pain? So multiple studies have shown that children who have undergone surgery with inadequate analgesia, later on in their life, their pain perception has increased. So this is not just in neonatal or childhood surgeries. It's this case even in children who are admitted in NICUs who undergo multiple procedures. Even in such small age group, if the pain is not adequately treated, it can lead to increased pain response later on in their life. So why does this happen? This is because of something called as sensitization. So as you can see in this graph on the x-axis, we have the stimulus intensity and how much pain is perceived on the y-axis. So this is the normal pain response. And once an injury happens, the graph shifts towards the left. So with the same pain stimulus, the the pain that is perceived is more than normal. So this is called hyperalgesia. And a stimulus which does not usually cause pain will cause pain. So this is called as allodynia. So these are the two effects of sensitization. Now this hyperalgesia that happens due to sensitization can be at the site of injury, which is called as primary hyperalgesia, or it can be around the site of injury as time passes. So this is called as secondary hyperalgesia. Apart from this, they can also experience spontaneous pain without any stimulus, and the pain can last longer than the actual stimulus. So this is called as after sensation. So the major takeaway from today's lecture is that there is no one size fits all for pain management. It has to be tailored as per patient need. It has to be individualized for each and every patient. So let's look at a couple of cases. Here we have a 8-year-old male child. Development is normal, uneventful birth history, no known comorbidities. He has now sustained a comminuted bone forearm fracture and is planned for open reduction and internal fixation. So when we see a child in the preoperative room, there are certain things which will tell us that this patient is more susceptible to pain. So we need to take a history about if the child has had any previous painful procedures, if the child or the patient is already anxious, or if there is any history of chronic pain in the child. Another point to note is that intellectually disabled children or children who have cognitive impairment, like autistic children, they also experience similar levels of pain as normal kids. Even though the assessment may be challenging, we have to do it. We have to ask the parent and take help from the family, and we should understand the pain and we should treat them adequately. Now this child, our pain management starts from the pre-operative period itself. So we need to sit with the child and the parent, and we need to tell them about the whole process that is going to happen. And we should reassure them that we will be taking care of their child. So even parental anxiety can increase adverse effects like pain and nausea in the child. So it is very important to explain to both the parent and the child as to what the procedure is going to be and how the pain will be taken care of. And while talking to the child, we shouldn't lie to the child. Like, say, if you're putting an IV cannula, we should tell the child that it is going to hurt a bit, but I will be gentle with you. So even if, so there's something called as nocebo, like inert things can also cause harm. So it's very important to not lose trust in the child. We should tell whatever is going to happen. We should make the child understand, but we should pick our words carefully. Another option of the analgesia in the preoperative setting would be using distraction techniques like having the parental presence. Again, like I mentioned earlier, you can play something on the mobile, the coloring book. Nowadays, even VR headsets are available where some cartoon can be shown to the child while he's being wheeled into the OT. Then there are options of pre-medication for a very anxious child. Again, it should be used with caution. So options like midazolam and dexmedetomidine are there. Midazolam, it can be given in multiple routes. So intravenous midazolam is 0.05 to 0.1 mg per kg. Oral midazolam, if we haven't secured an IV line yet, 0.5 mg per kg is the dose. And nowadays, even intranasal spray is available. So each spray will give 0.5 mg of midazolam, and the dose is 0.3 mg per kg. So 15 minutes before the procedure, you can go to the preoperative room, give the intranasal midazolam to the child. So by the time the surgery is about to begin, the child would calm down. Similarly, we can use intranasal dexmedetomidine also. The dose is 1 to 2 mics per kg. Need to give it like 30 minutes prior to the surgery. Now for IV application, we can explain to the child about the use of EMLA, which is a mixture of lignocaine and prilocaine in 2.5% each. So we will choose one or two sites where the vein is visible, and we will apply EMLA cream and place an occlusive dressing over it. So this should be done around 40 minutes before the surgery. So by the time the child comes into the OT, that area will be anesthesized. Now that the preoperatively we have made the child comfortable, intraoperatively, our plan is an opioid-based general anesthesia along with regional anesthesia, and we had chosen an infraclavicular catheter for this patient. So through this catheter, we will be given, like the doses were already mentioned earlier, 0.2% ropivacaine. Apart from regional anesthesia, IV analgesia can also be given, and our options are acetaminophen 15 mg per kg, fentanyl 1 to 2 mics per kg, morphine 0.05 to 0.1 mg per kg, IV ketorolac of 0.5 mg per kg, and IV diclofenac of 1 mg per kg. So this is like a multimodal analgesia that can be done intraoperatively. We need to tailor according to the needs intraoperatively. So coming to infraclavicular block, as you can see, it is this. We need to, the landmark is medial to the coracoid process. We can see the axillary artery running. So we have the brachial plexus cords around the axillary artery. So this is our area of interest. And infraclavicular block is, it gives a, like you can see in the picture, it has a very, very good coverage in the arm. So, we will use the high frequency linear probe below the clavicle in an in-plane technique. We will scan, and here we can see the two muscles, pectoralis major and pectoralis minor. And below that, we can see the axillary artery, and caudal to it, there's axillary vein. So the cords of the brachial plexus are around the axillary artery. So this is our area of interest. The needle that we use in children is what is shown here, which is a 5 centimeter needle, and it can be visualized under ultrasound. So since, and for postoperative analgesia, we can place a catheter through the needle. So the advantage of this is that since there are two muscles above, it will hold the catheter in place very well. Like you can see here, the catheter is fixed. And there is a lesser risk of phrenic nerve injury as compared to supraclavicular block. So in this particular case, along with general anesthesia, even options like axillary block and supraclavicular block can be given. So the problem with axillary is that the musculocutaneous nerve has to be covered under the catheter since it's a little away. So that is why we had gone with infraclavicular. It is a preferred mode of regional anesthesia in children. Now that the intraoperative part is taken care of, post-operatively, we need to periodically assess the pain in the child. Again, non-pharmacological options can be used. And since we have placed a catheter in the infraclavicular area, we will be using patient controlled analgesia. So this is the pump. It's just a sample pump. It's not the, so the drugs, just include the drugs that are mentioned here. So this, we connect this to the catheter, to the infraclavicular catheter. And this, the end of this wire has a button. So we need to explain to the child that there is a drug that is continuously going through this pump. And if at all the child feels pain, still feels pain, then he can press the button and adequate amount of analgesic will be given. So the use of PCA should be explained to the child and the parent, and it is approved for use in more than 6 years of age. So, provided the child understands how it needs to be used. So, for this PCA pump, we have filled it up with ropivacaine, 0.2%, and this pump, it has a basal infusion. We can set a basal infusion. That is, for ropivacaine, it would be 0.2 to 0.4 mg per kg per hour. And once the child, if the child is still feeling pain, he can press the button and an on-demand dose would go. That is 0.1 to 0.2 mg per kg. So to avoid an overdose, a lockout interval is also set around 20 to 30 minutes, depending upon the concentration and amount of drug that we are providing. So this is a very good mode of analgesia in the postoperative period. Apart from this, again, analgesia should be multimodal in the postoperative period as well. So there is, we can give IV acetaminophen of 15 mg per kg thrice a day, and IV ketorolac 0.5 mg per kg 12 hourly.
Harsha,
So
sorry
just
to interrupt, but we need time is like 8 o'clock. So can we move a bit fast, please? Sorry.
So
Yeah.
should I skip the MCQs?
No, we can continue, but
Okay,
we'll
so
do it
just
some
to
fast. Yeah.
just to make sure that
Yeah.
you all are awake, I'll
Mm-hmm.
put an MCQ in between.
Mm-hmm.
So the flag scale assesses pain based on facial expression, leg position, activity, cry consolability, facial grimace, limb movement, anxiety, crying, facial expression, language, activity, crying, comfort, or feeding, locomotion, alertness, crying, and consoling.
Dr. Gaurav answered
Um,
first A, and most of them
yeah.
have answered A,
Yeah. And Dr. Prem
except
is
an
there
occasional
is
D maybe.
answering fast. Yeah, good.
Yeah,
Nobody
very
is
nice.
asleep, that means.
No
Yeah.
one is asleep. It is very interesting.
Okay.
So a 2-year-old requires an IV cannulation. So to achieve analgesia with Emla Green, when should you apply it? Immediately before the procedure, 10 to 15 minutes before, 30 to 45 minutes before, or just after cleaning the skin with alcohol?
So most have answered as C. So
yeah, that's correct. So now that you've answered it correctly, we'll come to our second child, who's a 9-year-old boy, 40 kg weight. Again, the child has complaint of pain and swelling in the left knee since 2 months. So this, when we have a child who is in chronic pain already, we need to ask a few questions to assess the type and severity of pain. So this pain is severe and it aggravates on movement. It is a shooting kind of pain associated with tingling along the medial side of the leg. So this means that there is a neuropathic or nerve involvement in the pain. And this child is posted for tumor excision of proximal tibia. So when you get a case of acute on chronic pain, we need to take the analgesic history also. So the child is already on ibuprofen and gabapentin. Like I said, the concerns in this case are that it's an acute on chronic pain. So we should cover both the components while treating pain. And since it's a major procedure on the limb, the child and the parent might be very apprehensive about losing the limb and also about the postoperative pain associated with it. So it's important that we start angiolysis at the time of the preoperative evaluation itself. And also we need to keep in mind about the dosing of analgesics since it's a major surgery, blood loss, hypertension kind of. So here in this particular case, we thought of giving general anesthesia along with pop-sciatic and adductor canal catheters to cover the regional anesthesia component. Apart from this, there could be other options like epidural, and details of which has already been covered. Femoral plus saphenous nerve block, intrathecal morphine in 3 to 5 mics per kg, And like mentioned earlier, again, IV analgesics, fentanyl, morphine, acetaminophen, ketorolac, diclofenac, and apart from this, even local site infiltration can be done in this particular case. So for this sciatic nerve block, as you can see, the probe should be kept in the posterior part of the leg, a little above the popliteal fossa. That is where the sciatic nerve divides into the common peroneal and the tibial nerve. So as you can see, this is the dynamic scanning from above downwards. The point where the sciatic nerve divides into the common peroneal and tibial, between the two nerves, this is where the block is administered. And the second block, which I had mentioned, was adductor longus block. Both these blocks, we can use catheter for postoperative analgesia. So this is again from ASIS to the patella, the midpoint of it. At the apex of the femoral triangle, we have the sartorius and adductor longus medially, and the vastus medialis laterally. So above the femoral vessels, anterolaterally actually, we can see the saphenous nerve, and this is our site of injection. Now, post-operatively, since this child already has a neuropathic component to pain, we need to see how to recognize that. So like earlier mentioned, there's burning, tingling, numbness, sweating, and increase in temperature. So this should be compared with the other limb. And the type of pain will be shooting pain, stabbing, and there can be features of sensitization like allodynia and hyperalgesia. And the options for treating neuropathic pain are gabapentin and pregabalin. Doses are mentioned. So now when we see a child in the postoperative care unit, pain is not the only cause for any child that's crying. So we need to evaluate it. It could be because the child is in the hospital, it's a new setting, new people. So the child might need parental presence, or the child might just not want the IV cannula, or the child might just have a full bladder. So we need to assess everything before we start treating the pain. So before I wind up, a couple of easy MCQs. So the gold standard pain scale for an infant is.
Well done, Dr. Nitin.
So a lot of people are answering.
Yeah, so fast they are answering. That is really appreciable.
Yeah, A is the right answer. Plaque is this.
Yeah, mostly they have answered A only. Yeah.
Preemptive analgesia in pediatric surgery primarily aims to reduce intraoperative bleeding, prevent central sensitization and reduce postoperative pain, shorten anesthesia duration, or replace postoperative opioids.
So answer they have given more than 7-8 answer are B, option B, B for Bombay. Yeah.
Well, a couple of people have answered D, so it's not for replacing postoperative opioids. The correct answer is B, is to prevent central sensitization and reduce the postoperative pain.
Yeah.
A 3-year-old child undergoes a femur fracture fixation. Postoperatively, the child is inconsolable, and the plaque score is 8 on 10. So what is the most appropriate next step in analgesia? Wait and reassess, administer weight-based IV opioid, give oral acetaminophen, or apply cold packs alone.
Except one, others have answered B, B for Bombay.
Yeah, so since this is immediate post-op, the pain intensity is high, anything more than 7 is high. So we need to start from the top part of the ladder. We need to start from opioids and then gradually de-escalate as the days pass by. So the correct answer is administer weight-based IV opioid. So that's it from my side. Just to summarize, the pain in early life should be taken very seriously. Otherwise, it can alter the pathways and lead to a lower threshold for pain later in life. We need to communicate in gently and make the child understand everything properly. Multimodal analgesia is key, and an individualized approach is needed when treating pain and children. Thank you.
Thank you, Harsa. It was a wonderful session. Uh, Nishant sir, Bajwa sir, it's 8:10. Can we take 5-7 minutes more? Is it possible?
We are going to have a particular session or what?
No, just 5-7 minutes of crux of everything. Actually, they have covered almost everything. Some
Mhm.
salient points I just wanted to add. If you permit, it will take 5-7 minutes.
Yeah, yeah. Please go ahead.
Okay.
And also, Mithilesh, there was a question somebody had put on for Kriti to comment on the role of dexmedetomidine, dexamethasone, magnesium, and ketamine in pediatrics, sedation, analgesia.
Yes, ma'am. Yes, ma'am. Kirti, do you want to attempt by the time I'm sharing my screen?
Unmute yourself, Dr. Kriti.
Huh. Am I audible now?
Yeah.
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 Yeah. Okay. So what are the role of adjuncts is what he was asking me, I think.
Yeah.
Yeah, okay. So depending on what block we are using, it depends on that, the dose, the age, again, everything. So suppose if you want me to comment on dexmedetomidine. So dexmedetomidine can be used from 0.5 mic per kg to up to 2 microgram per kg, whether you're giving in a peripheral nerve block or whether you are giving in a caudal single shot. It depends on all of that, but the major consideration that you have to keep in mind is the age of the child and the hemodynamics of the patient. So dexmed we know causes a lot of bradycardia, hypotension. In babies, hypotension is something we generally tend to overlook. What we are more bothered about is the heart rate, and that is the soul of everything. When the heart rate falls down, of course, there's going to be a problem. So to be very careful at what dose are you giving that, and especially we try to avoid it in neonates. That is where we don't usually give it. Even in infants, if it has to be given, then it has to be given in the lowermost form of the range that we are giving. Similarly, if we are using for a bigger child, then yes, we can give it. We can give up to 2 mics per kg. It has safely been used. It's been published for all the peripheral nerve blocks. Then coming to dexamethasone has an excellent adjuvant capability. Again, 0.1 mg per kg is the dose that we use in peripheral nerve blocks. Be very sure that you want to use dexamethasone when you really want to prolong the action, because practically when we use it, what we observe is that it prolongs the action for almost 8 to 18 hours. And suppose you're using it for a fracture in the arm or something like that, babies are, they'll have a lot of problem because they want to move their hand. They are not able to interpret the fact that okay, it is giving analgesia, and that is the reason it's not moving. So they'll be more fretted by the point that now it's not moving. So you have to be very careful with those age group where you can't explain them what is happening. So in that case, try to move on to a different alternative, maybe fentanyl also 1 to 2 mics per kg is very good. Other than that, what did he ask me? What all?
Vitamin, magnesium, we don't have much evidence in
Uh,
pediatric age group.
yeah, I mean, magnesium 30 to 50 mg per kg is something which is recommended, but usually, I have not used it. There has been just one instant where we had to use it for a particular patient, but other than that, we have not used it. So I'm not very sure how good or bad it is, but yes, there's a lot of evidence on it and looks, but when we have these alternatives, um,
These all are off level. Mostly, what for neuraxial, if you want, it is fentanyl, epinephrine, and clonidine, which is approved. People are using, even in Miller, they are mentioning all these things, but these all are off level. Shikha ma'am, you want to add something?
Yeah. No. There is another question for Kriti. How to decide epidural catheter length in pediatric patients? I think this will be the last question.
Yeah.
okay. So Pediatric catheter length, a very simple, there are a lot of formulas for that actually, if you see, and it's almost impossible to remember because there's a separate formula for age 3 months to 1 year, then from 1 to 4 years it's different, then 6 years onwards it's different. It's very difficult to remember all of that. As a thumb rule, what you can remember is that it is usually zero point 0.1 into the weight of the patient, that much centimeter. So, for example, if it is that much millimeter, I mean, I'm sorry. So, if it's a 10 kg child, you will encounter the space at 1 centimeter, 20 kg child, 2 centimeters, roughly something like that. And how much to put inside, if you're asking me how much to thread inside, then roughly
I
I
think we
think,
lost.
yeah. So it is not more than 3 centimeter, a rule of three. Keep it for not more than
about,
3 days, and it is like not more than 3 centimeter inside.
sorry, sir, I couldn't hear
No,
if you're
we
saying.
lost your connection. I'm just adding to
Oh,
it that it is the maximum 3 centimeters should be inside and kept
yes.
for not more than 3 days. Yeah.
So now we move to Mithilesh for summing up.
Yes, ma'am. I'll just take 5 minutes, ma'am.
Yeah,
So,
yeah.
for students' exam point of view, I will cover only those salient points. We are already late. Maybe if Bajwa sir will allow next time, I will cover the rest of the thing in that class. So, first of all, wherever there is pain, this is it starts from the new definition by IASP that everybody has to remember as it is given. It took more than 60 years to come up with a definition of pain. Okay, these are some barriers. Our students have already covered a lot around this, so we'll not be going anything in detail. We need to treat pain in pediatric. It is as important as adult. In fact, it is more important because it has been proven that if you are not treating the acute pain, there is a long-term effect on pediatric patient. These children have chances of depression, becoming criminal minded. The turning chances of acute pain becoming chronic is too high. So acute pain management is very, very important. And your job as an anesthesiologist, it is your job to treat it properly and adequately. Okay, assessment part mostly covered. We question the kid. A kid more than 3 years can understand and interpret NRS. Okay, this quest approach is the most recommended evidence-based approach for assessing the pain in the pediatric age group. Which tool we should use? Make a protocol institution-wise that though there are more than 60 pain scales available for pediatric age groups, some are univariate, some are multivariate. Choose a scale, do some study on that, and use in that. Suppose a kid is less than 6, I'm going to use this. Kid is 6 to 1 year, I'm going to use this. That test should be reproducible, reliable, valid, and transferable. Not the same person is doing all the time. Even if somebody else is assessing in recovery, in pre-op, and post-op, it is it should be transferable and reproducible. Okay, these are some strategies for pain assessment that has been covered. This phase you should remember. If you see a kid with a mother in pre-op, you can find out what are the differences you see post-op. And if you can find out, it is well and good. Else involve the parents also in assessment and management of pain, and they will help. Okay, if patient is under a GA, there are so many cons of that. We need patient, children, pediatric patient under general anesthesia for putting any injection for their safety, but they are not that safe. Okay, so these are some physiological measures we see when pain is there. Okay, I will skip all this. This has been covered already by our presenter. Coming to this, what are the differences you see in between adult and pediatric? First and foremost, when we read the evaluation, spine is straight at birth. There is no curvature. Only thing, there will be lumbar lordosis once they start moving. So needle placement is very important. You don't need to put as in adult that in thoracic you are making 45-degree angle, and in lumbar you are going straight. So most of the places it is still cervical. We don't touch unless until there is some phantom pain or there is some we need for vasodilation. We don't touch. Thoracic we are using very frequently. Lumbar we are using frequently. Caudal, almost everybody should know. Okay, now if we are giving a block under general anesthesia, we don't know where we are irritating or injuring a nerve. While putting the needle, a tissue which belong to other area moving to another area can cause growth and tumor in that place. We have to be very, excoriation is very common. The myelination is not complete till 1 year of age. So these nerves are more sensitive. So local anesthesia dose should be, if you have a range, touch the lower, try for the lower range first. Okay. Ropivacaine is preferred over bupivacaine. Reason they have told already, it has a selective effect, less motor, less cardiotoxic. S enantiomer allow us to give a dose. In neuraxial, we don't need to preload pediatric patient till 8 years of age. There is no hypotension, there is no sympatholysis. We should remember the anatomy. In adults, spinal cord ends at L1, L2. In peds, it is L3, L4, and dura goes up to S3, S4. So even if you are putting a caudal block, caudal needle, I will recommend to go only by ultrasound. If you have in your OT, use it. If not, do not put the tip more than 0.5. The chances of dura puncture will increase if you put the needle more than 0.5 centimeter in the caudal space. Puncturing dura, giving the dose which we are planning to give in caudal can goes up to thoracic and above level. So be very careful. Okay. Delayed myelination, I have covered. Cartilaginous bone. So you can even puncture the bone itself if you apply more power. So we use curved needles, short bevel, B level needle we use 30 to 45 degrees so that we have better feel of the structure we are piercing. Okay. The sacral hiatus, suppose we have to feel it below. The L45, the tougher line, the lowest line which we measure for adults, that correspond to L4, L5 in adults, but in pediatric age group, it is L5 and S1. The tougher line is at L5 and S1. Okay. The epidural fat is more liquid, more fluid. That gives one benefit also, that we can pass the catheter from caudal area till thoracic area. But it will give quicker action, short duration action, and dosage required will be more. So these are the fascial pain blocks we are giving using in pediatrics. All are proven helpful. Depending upon your expertise, you can use. Drugs, you have to thorough decide how much duration you want, what concentration, note it down, document it in the PSC chart or your pain chart, how much you have given, so that if repeat is required, the second person who's looking after should know how much already given. Local anesthesia toxicity is more common in pediatrics. These are the adjuvant, the question asked, I have put it in the slides. I will share with you all. These are the recommendation. This is from Miller's anesthesia book. Okay. Chlorprocaine, again resurging because of its short duration. Previously, we were stopped using because of the components, but it is resurging. Most commonly used is bupivacaine, most of the places. Most preferable is ropivacaine, though ropivacaine for spinal and fascial, still we need some more evidence. Okay, these are the doses for plexus block and interfascial block, how to calculate. These are some off-level issues. ISRA has come up with blocks in green and pink, which the level of expertise and the level of evidence available for this. Okay, if we see what are the problems, when what are the risk we give. So if we are planning interscalene, the nerve palsy, phrenic nerve, Horner syndrome, if we are supraclavicular, chances of pneumothorax is more. We have reduced this complication by using ultrasound. With ultrasound we can target supraclavicular also. For single time it is better. If we want catheter, Dr. Harsha has explained that for placing the catheter, infraclavicular is preferred. Okay, intralipid dosing, ma'am has told already, 1 to 1.5 ml per kg bolus. It should be available inside the OT. By the time it is prepared or procured, you should stop the further giving of dose, oxygen, airway support, epinephrine if required, and give intralipid as early as possible. USG, it is not always safe. It has a long learning curve. So while you are starting giving blocks with the ultrasound, try to go for simple blocks first. Train your brain for the probe and needle manipulation. Try to search, try to use in plane technique in most of your blocks. At beginning, do not try out of plane. See the needle tip all the time. If you are planning for any stimulation of nerve, sensory or motor, prefer 5% dextrose in place of normal saline or local anesthesia. That will give a better stimulation. Okay, hydrodissection before giving local anesthesia, putting Doppler, and fix your trajectory that you are not going to puncture any artery or vein while putting the needle. Always give in a small aliquots, aspirate and go. Okay, these are some complications of ultrasound. Okay, so I think I should stop here. Rest all, it's a big topic. We tried our level best and we are open for questions, anything. The final slide is, even if surgeon says that I'm not happy, the pain relief is not adequate, you yourself feel in the post-op that whatever effort you have given for pain relief is not adequate, accept it, try it, learn it, and practice more. Even in the best of the practice person, the failure rate is 20 to 30%. Only thing is you are going to relieve the pain of the patient by your knowledge. One thing failed, we have a plan B, plan C, plan D. I will relieve the pain. How? That will depend upon the situation. So do not ever dishearten that you have given this block and it has not worked. It happens with everyone. Thank you. Thank you, sir, for giving this opportunity. Thank you so much. Sikha ma'am, you want to
Yeah.
add something, ma'am?
Yeah, thank you, Mithilesh. Very well summarized. I think you covered everything and even the thoughts. And I really liked that your ego should never come in the way. I
True.
liked that point which you mentioned. Nice.
Thank you, ma'am. Thank you, ma'am. Uh, Bajwa sir, thanks to you.
Yeah, I think this was a very absorbing uh, class by all standards. So what was being explained, just want to add there one thing, that since the right from the birth to till the infant stage, the development of the brain, the nervous system, the peripheral nerve, the myelin sheath, it's not standardized that at particular time this will be developed. It varies from patient to patient also, from one child to other child. So the pain perception, the pain relieving, the dosage, the real dosage calculations, they're really difficult to measure, even in spite of our best knowledge, what we have gained from the literature or from the experiences. It's still a very, very challenging job. Although we may be having the so many scales developed over the years, but I think in the going into the future with the development of the AI, and I think which can be taken for help. Pain scores in a developing brain, if you want, in the first year, I think what we were considering also, it has been under consideration for a research purpose also, and to establish the real pain therapeutic interventions, that going for the base, going for the DSA, or just for certain those non-invasive electrodes on the brain during the pain feeling. I think they can really differentiate. You can correlate with the clinical parameters, you can correlate with the facial expression, you can correlate with so many things. The brain will be the tissue, how the developing brain behaves along with the pain. I think those are in already in a pipeline, the research studies. Those will definitely convey how we are really going to have more control or more precise the precision medicine coming into play about a pain relief in the pediatric patients, not exactly pediatric in the infants. So those things are also underway at many centers, not in India, at global level also. I'm also part of one of that study also. So this is one thing, and the one of the Dr. Kriti was answering in a very, she answered in a very well manner. So that was very important. That there were so many adjuvants, so many alternative drugs. I think when you are using the drugs in a pediatric case, do use only those drugs which you are most comfortable, which you are most used to, which you know that there is no adverse events associated with these drugs. They can be the one last line you said, the patient safety, then the ego, patient safety, then the adventure, patient safety, then the glory. So many things are there. Those should be always primarily on your mind when you're treating such patients. That is how think we should be going for the pediatric pain management. It's a tough topic, but I think you people covered it so well, and it will remain etched in the history because the recording will remain on the YouTube channel of ISA NHQ, and it will be available to everyone anytime, anywhere in the world. You can access to that. That's a freely accessible, no charges, no paid subscription, and the people will be thanking the Institute of Gangaram Hospital so that they have provided one of the best class on the pain management in the pediatric patients. So I'm really proud of that it has been a beautiful class. So thank you
Wonderful.
very much. And
Thank you.
I think it's a time for us to, as felicitation also, just just wait. Is my screen visible, Dr. Mithilesh?
Yes, sir.
So, Shikha ma'am, you being the overall mentor of this class, thank you very much for everyone for preparing everyone. This has been a wonderful class. Thank you very much, madam.
Thank you, sir. Thank you.
Yeah. And Dr. Mithilesh, I think you write as a captain of the this one presenters. So you summarize it very well in the last, and the last slide was the best slide for me. That was a take-home
Thanks a
message,
lot,
and that's
sir.
I think,
You started this, and thanks a lot for this opportunity.
yeah. Thank you, Dr. Mithilesh, for that.
Thank you, sir.
And Dr. Kriti, she worked very hard for her presentation, and she was the opening batsman, and she did so well that she made the pain management so simple.
She
Thank
has
you,
done
Dr. Kriti.
everything. She has presented and moderated everything.
Yeah, yeah, it's a double game she played as a
Yeah,
captain as well as a player.
yeah. You could see that it was coming from the
Yeah,
heart.
yeah.
Yeah.
Yeah,
And Dr. Harsha, you were equally good. You prepared well, and as a trainee, fellow trainee in the pain medicine, I think you are
She
going to do wonderful
prepared
job
very
in the
well in
coming days.
very less time. Yeah.
In the
Thanks a lot,
coming days,
Harsha.
you will be doing. Yeah,
very well
thank you
done,
very much.
Harsha.
And our last, Dr. Shirisha, in the last moment, she took over as a coordinator, as a screen coordinator. So thank you, Shirisha. You did hold that fort also very well, and you compiled things in a good way. Thank you, Shirisha, for being the screen coordinator.
Thank you, sir.
Thank you,
And
Shreya.
and
Thanks,
I
Nishant,
always,
sir, Madhuri, ma'am. Thanks a
yeah,
lot.
no, it's me who have to thank them because they are helping me to help my thing. Dr. Madhuri, Dr. Nishant, Dr. Ridhima, they always help me in my classes because you can see that the classes are always good. And because the hard work goes behind, you must have seen in the last 2 days also that how hard work has to be put to make it more
Yes, sir.
precise and useful.
True,
So
true.
thank you very much to my team always. So I think in the last 2 minutes, if somebody wants to add something, then we can close the class.
Or from a student side also, if anything, any addition you want us to modify or any suggestion is welcome.
I don't think Mithilesh, I think everybody
Everything
had a very
understood.
good time. Yeah.
Okay. Okay, ma'am.
Yeah,
Okay.
everything understood. So we all